If you've ever felt confused by conflicting medical advice about aspirin, you're definitely not alone. In fact, over the past decade, the medical guidance on aspirin has swung like a pendulum on moment, hailing it as a miracle drug, the next warning of its potential dangers. But let's be clear about one undeniable fact: each year, hundreds of thousands of people will suffer a myocardial infarction, also known as a heart attack. Many of them, far too many, will not see it coming. And here's the most astonishing part. Most of those heart attacks aren't simply caused by the long-term buildup of high cholesterol. The causes of a heart attack often stem from a far more sudden and dangerous scenario: a blood clot that forms in an instant, cutting off the blood supply that nourishes the heart. Imagine your arterial system as a vital traffic network where blood flows without interruption. Until one day, a hidden plaque ruptures somewhere similar to a major accident, paralyzing an entire highway. In just a few seconds, the entire transport system shuts down. That's precisely what happens inside your body, and this is the reason of a heart attack that many people don't fully understand. This plaque rupture event triggers a defensive response from the body, forming a blood clot to patch up the injury. This process is gender neutral. It occurs similarly in a heart attack in women as it does in men, and it's also the mechanism that causes an ischemic stroke. And aspirin in this context is not just a common pain reliever. It's one of the few tools capable of directly intervening in this process. Its role is to reduce the stickiness of platelets, preventing them from clumping together to form a fatal blood clot at the most critical moment. This is the key to prevent a heart attack right when it's about to happen. However, a concerning reality is that many seniors today are stopping their aspirin on their own without any testing or professional guidance. Some do it after reading a news article, while others follow general guidelines stating it's no longer recommended. And aspirin, in this context, is not just a common pain reliever. It's one of the few tools capable of directly intervening in this process. Its role is to reduce the stickiness of platelets, preventing them from clumping together to form a fatal blood clot at the most critical moment. This is the key to prevent a heart attack right when it's about to happen. However, a concerning reality is that many seniors today are stopping their aspirin on their own without any testing or professional guidance. Some do it after reading a news article, while others follow general guidelines stating it's no longer recommended. But here is a harsh truth. Some of those people ended up in the emergency room, or worse, simply because they misunderstood who the new medical guidelines were really talking about. So let me ask you a direct question. With your own heart health on the line, are you absolutely sure you're doing the right thing to protect yourself? Have you ever had advanced testing to check for plaque or calcium buildup in your arteries? Or are you just assuming you're fine because you don't feel any signs of a heart attack? Could stopping aspirin be your silent and most serious mistake? Because the issue here isn't about following the latest medical trends. It's about adhering to evidence-based medicine that applies specifically to your individual situation. In this video, I will walk you through in detail exactly how aspirin works to protect you from cardiovascular events, when it's truly necessary and when it's not. More importantly, I will show you how to know your real risk, even if you feel perfectly healthy. The ultimate goal is to help you answer the question, how can we prevent heart attack most effectively? Together, we will make a decision not based on fear or confusion, but on a solid scientific foundation. Because this isn't just about one little pill. It's about giving you peace of mind control over your health and possibly a second chance at life. Let's get to the heart of the matter, literally. Most people still hold a common misconception that heart attacks are simply caused by cholesterol, slowly building up and clogging arteries like grease, solidifying in a kitchen pipe. But modern cardiology tells a completely different and far more frightening story. The real killer isn't just the silent process of plaque buildup. It's what happens when one of those plaques suddenly ruptures, tearing open like a raw wound right inside your artery wall. When this event occurs, your body immediately recognizes it as an injury that needs to be repaired. Instinctively, it initiates a clotting process to seal the tear, similar to how it would heal a cut on your skin. But ironically, inside an already narrowed coronary artery, this rescue blood clot becomes a deadly obstruction. In just a few seconds, the clot can expand and completely block the oxygen-rich blood flow to a part of the heart muscle. This is the very moment a person begins to feel the symptoms of a heart attack. What is that sensation? What does a heart attack feel like? Often, it's a severe chest pain, a crushing sensation. But sometimes heart attack symptoms in women are more subtle, like nausea, jaw pain, or sudden exhaustion. This blockage is a myocardial infarction. And if it disrupts the heart's electrical system, it can lead to a cardiac arrest, an even more critical condition. And this is where aspirin comes in. Aspirin cannot dissolve atherosclerotic plaques, nor can it clear out long-standing blockages. Its mechanism is far more subtle and crucial. Aspirin interferes with the ability of platelets, the cells responsible for blood clotting, to stick together. Imagine platelets as little bricks trying to stick together to build a dam that blocks the flow in your bloodstream. Aspirin works by preventing those bricks from stacking up too quickly. Medically, it significantly reduces what's called platelet aggregation. By doing so, it directly prevents a deadly clot from forming on a freshly ruptured plaque. Because of this powerful mechanism, aspirin has been a cornerstone medicine for heart attack in secondary prevention strategies for decades. This means that if you've already had a heart attack, a stroke, had a stent placed, or been diagnosed with atherosclerosis, then taking a low-dose aspirin daily, typically 81 mg, can dramatically reduce your risk of a second, potentially fatal event. Reputable studies, such as the one published in the New England Journal of Medicine in 2002, have shown that aspirin can reduce the risk of a recurrent heart attack or stroke by up to 25 to 30% in high-risk patients. However, this is where things get complicated and confusing. In recent years, large-scale studies like ARRIVE, ASCEND, and Aspirin have reached a surprising conclusion. Aspirin may not offer a clear benefit for primary prevention. That is for people who have never had signs of stroke or heart attack and have no evidence of plaque buildup. What's the reason? Because in people with low to moderate cardiovascular risk, the risk of internal bleeding, especially gastrointestinal bleeding, or even a cerebral hemorrhage, may outweigh the benefits of preventing clot formation. It is because of this balance between benefit and risk that in 2022, the U.S. Preventive Services Task Force, USPSTF, updated its guidelines. They no longer recommend routinely starting daily aspirin for adults 60 years or older who have never had a heart attack or stroke, the primary prevention group. For people aged 40 to 59, the decision should be an individualized one based on a thorough discussion with a doctor about risk factors, family history, and coronary artery testing results. And this is where the most harmful misunderstandings arise. These guidelines simply do not apply to people who are already in the high-risk category, those with a prior history of cardiovascular events, evidence of calcium buildup on a CT scan, or signs of atherosclerosis on an ultrasound. For them, aspirin remains one of the most powerful tools we have to prevent a recurrent heart attack. The biggest mistake is to see aspirin in black and white. Either it's good for everyone or it's bad for everyone. Medicine is never that simple. In reality, aspirin is like a fire extinguisher. It's a lifesaver when there's a fire, but you wouldn't spray it all over your living room just because someone lit a candle. You have to know your fire risk before you decide whether to equip it. Sadly, the media often oversimplifies the science. A headline like "Aspirin no longer recommended" causes people to panic. They stop their medication on their own, not realizing they are in the high-risk group just because they don't have any warning signs of a heart attack. And for some, that decision can be a catastrophe. You see, the most dangerous thing about atherosclerotic plaque isn't its size, but its instability. Even a small hidden and seemingly harmless plaque can rupture, causing a fatal blood clot. A soft plaque full of lipids and inflammation can be far more dangerous than a large but calcified and stable one. The frightening part is that you absolutely cannot feel the process of plaque forming. There are often no early signs of a heart attack. No signs before a heart attack to prepare you. This is why, for many people, the first heart attack is also the last. And it's also why so many cardiologists continue to prescribe daily 81 milligrams as aspirin to patients who have had any kind of cardiovascular event or those with confirmed evidence of artery disease. The science still strongly supports this for that group. Even with the signs of a heart attack in men, which are often considered more classic, the dangerous phase of plaque buildup still happens in silence. The key here is to know who you are in this picture. Are you in the low-risk group, or are you walking around with a ticking time bomb in your chest without even knowing it? If you've never had a calcium score test or never had your arteries checked for plaque, then stopping aspirin could be a premature decision or even a dangerous gamble with your own life. On the other hand, if you've been taking aspirin just in case while you are perfectly healthy with no evidence of plaque, no prior cardiovascular events, and no major risk factors, then yes, that aspirin might be unnecessary or even more harmful than beneficial. The difference between a heart attack versus a stroke is real, but both are serious vascular events that we need to prevent intelligently, not indiscriminately. And this brings us to the most important message of this entire conversation. Don't guess, don't play doctor, don't just blindly follow sensationalist headlines. Your heart deserves more than that. It deserves clarity. It deserves precision, and above all, it deserves a protection plan built around your own body, not the general population. Self-diagnosing based on symptoms is extremely risky because heart attack symptoms, men versus women, can be very different. Here is a harsh truth: too many people are taking aspirin when they shouldn't, and far too many have stopped taking it when they still truly need it. So, how do you know exactly which group you belong to? Let's start by dispelling this fog. If you have ever had a heart attack, a stent placement, a stroke, or been told by a doctor that you have significant plaque buildup in your arteries, then you do not belong to the general population. You belong to the group that doctors call secondary prevention. In your case, aspirin is not an option. It is an essential factor. Why? Because your arterial system has already proven that it is vulnerable to dangerous plaques, unstable materials that can rupture at any moment without warning. And when that rupture happens, it triggers a blood clot. In this context, aspirin can save your life by significantly reducing the likelihood of that clot forming. It acts as a final line of defense, a critical safety measure to prevent a recurrent heart attack. But what if you've never had a heart attack? What if you feel perfectly healthy? You manage your blood pressure and heart attack risk with medication. You eat salads and you walk every day. This is precisely when we need to dig deeper, not into how you feel, but into what is actually happening inside your arteries. Because here is a truth that few people will tell you: you can absolutely have dangerous plaque without any symptoms whatsoever. In fact, up to 50% of people who die from a heart attack never had any early warning signs of a heart attack beforehand. No chest pain, no shortness of breath, nothing. If you are waiting for a symptom to warn you that it's time to act, you may already be too late. Sometimes the signs can be very ambiguous. For instance, a heart attack and a panic attack can have overlapping initial symptoms like a racing heart and shortness of breath, causing people to dismiss them. This is precisely when advanced diagnostic imaging tests come into play. They are tools that go far beyond the standard cholesterol or blood pressure readings you regularly check. Below are 3 ways to know your real risk instead of guessing. Method number 1, and perhaps the most important, the coronary artery calcium CAC score. This is a specialized, non-invasive CT scan that accurately measures the amount of calcified calcium in your coronary arteries. Calcium in this case is a hard marker, undeniable proof of the long-term presence of atherosclerotic plaque. A score of 0 is an extremely reassuring signal indicating that your risk of a heart attack in the next 5 to 10 years is very low. But a score of 100, a MARD 300 or higher, that means there is a significant plaque burden and you are facing a real risk, even if your cholesterol levels are completely normal. Method number 2, the carotid intima media thickness, CIMT test. This is a painless ultrasound test performed on the neck to measure the thickness of the inner layers of your carotid arteries. Why the arteries in your neck? Because they are a window that reflects the health of your body's entire vascular system. A thickening of the artery wall or evidence of plaque here indicates that you already have early-stage vascular disease. CIMT can detect these changes, sometimes even before calcium has formed, and can be seen on a CT scan. Method number 3, inflammatory and metabolic blood markers. Many people just wait for classic heart attack warning signs like chest pain or heart attack arm pain. However, advanced blood tests can detect risk long before that. Tests like high-sensitivity CRP-HS-CRP, fasting insulin HbA1c, and oxidized LDL help to reveal the inflammatory environment silently brewing inside your body. Inflammation is the very factor that makes plaques unstable and more likely to rupture. If any of these tests show risk, if you have a high calcium score evidence of thickened artery walls or signs of metabolic dysfunction, then using aspirin may be a reasonable strategy even if you've never had a heart attack before. This is no longer a guess, it's a calculated strategy, and it could be the fine line between life and death. But what about the bleeding risk? Isn't that the main reason aspirin has fallen out of favor? The answer is yes, and also not entirely. Aspirin, like all medications, comes with risks. The most notable is gastrointestinal bleeding, especially in people over 70 or those with a history of stomach ulcers. That is why every decision to use aspirin must be weighed on a scale: on one side, the risk of bleeding, on the other, the risk of a cardiovascular event. This is not something you can decide for yourself based on an online video or an article. This is something you must do with your doctor with the actual data from your arteries in hand. This is also precisely why making changes on your own without testing is so dangerous. Too many people assume they are low risk simply because they are not in pain. But remember, pain is a lagging indicator. Plaque can build up silently for years. If left uncontrolled, prolonged atherosclerosis not only leads to heart attacks, but can also weaken the heart muscle, gradually leading to other conditions with their own distinct heart failure signs and symptoms such as shortness of breath on exertion or swelling in the legs. And here is something else most people don't realize: not all plaques are the same. Some plaques are calcified and have become stable. Others are soft inflamed and far more likely to rupture. That is why two people with the exact same cholesterol level can have completely different outcomes. So, if you have never had any advanced vascular testing and you are over 60, it is time. Not because you are sick, but because you deserve clarity. You deserve to know whether or not you are carrying a silent threat in your chest. So let me ask you this. When was the last time you got a full picture of your artery health? When was the last time your doctor sat down with you, looked beyond your cholesterol number and asked, "Do you have early plaque? Should you be on aspirin?" If the answer is never, then you may be flying blind with your health. And that is not how we protect our hearts. So let's recap clearly. You should seriously consider taking a low-dose aspirin, usually 80 mmol, if you have had a heart attack, including a minor heart attack, a stroke, or a stent, have been diagnosed with atherosclerosis, have a coronary artery calcium TAC score over 100, or have tested positive for inflammatory markers and metabolic syndrome. However, the most crucial prerequisite is that your doctor has evaluated your bleeding risk and given you clearance. Conversely, you should not start aspirin without testing. If you have never had a cardiovascular event, are under 60 with no signs of disease, have a history of gastrointestinal bleeding, or are already on other blood thinners. And always keep this in mind: never start or stop aspirin suddenly without talking to your doctor. Because aspirin is not simply good or bad. It is a powerful tool, and like any powerful tool, it must be used the right way at the right time for the right person. Now that you understand how aspirin works and when to use it, the next step is to act based on your personal risk, not on general advice. The worst thing you can do is say, "Well, I'll get to it someday," because heart attacks don't wait for the perfect time. They strike in silence. So the action you can take today begins with getting tested. Don't guess, measure, and ask your doctor about getting a TAC score. Next, talk to your doctor with a plan and the knowledge you now have to foster a deeper discussion. At the same time, remember that aspirin is no substitute for the fundamentals of a healthy heart. Quitting smoking, eating a healthy diet, and exercising regularly. Finally, share this knowledge because you now hold information that could save someone's life. Send this video to a loved one who is confused about aspirin and encourage them to get tested instead of guessing. Because in the end, heart disease is still the #1 killer, not from a lack of medication, but from a lack of personalized prevention. Your heart is important, and you deserve to protect it with clarity, not confusion. Thank you for watching until the end.